Hello, everybody. Good afternoon. Welcome to today's medication-assisted treatment echo clinic. So great to have you joining us. A couple of new faces and then some of our regular participants. So we'll go around and do introductions for everybody. So hi, Troy Jorgensen, Program Manager, Project Echo Nevada.
I'm Corinne, I'm a pharmacy student.
I'm Shalene, I'm the pharmacist at Hopes, Nevada.
Mark Broadhead, addiction psychiatrist, VA Medical Center, Reno, Nevada.
I'm Echo Troop. I'm a licensed clinical social worker on the MAT team at Northern Nevada Hopes.
I'm Kim Nishik. I'm a physician assistant at Northern Nevada Hopes for the MAP program.
And I'm Amy Smith. I am Project Echo assistant.
All right.
So I'll jump out here and update you guys.
Yep, so we'll go around the group here. So just a quick reminder that we do record all these sessions. So if you don't want your video used, just let us know. And then if you do present any cases, just remember to not disclose any protected health information. Amy, go ahead. All right.
So, okay. So Mark Broadhead again, we're just gonna, there's a limited number of slides here. We're just gonna kind of go through fairly quickly. This is kind of looking at, well, when might you want to use buprenorphine and when might you want to use naltrexone. We're going to tend to focus in on, because we're comparing these two with opiate use disorders, but remember naltrexone can also be used for alcohol use disorders, and I think that's probably where it's primarily used outside of criminal justice systems, but it does have a significant role in helping with opiate use disorders. Next one. Me? Oh. Just kind of quick background. The thing to remember is that our opiate receptors, we can have what they call full agonists. All of our medications we're looking at, even though there are a bunch of different opiate receptors, we're primarily focusing in on the mu receptor. You know, for pain management and for addictions. A full agonist is something that will stimulate the mu opioid receptor and give it a full response. A partial agonist is something that will bind to the receptor and give it a partial response. That's what we're talking about when we talk about buprenorphine. Buprenorphine binds to the mu receptor, and we'll talk about the avidity with which it binds. That's a very important factor. But it will only stimulate it to a certain degree. There is a ceiling effect on this drug. Once you get past 16 milligrams a day, you've pretty well saturated every opiate receptor in the mu opiate receptor in their body. This is variable. But 16 is usually the number cited as, you know, where you're going to get a significant number of people who above that won't get any effect from it one way or another. You can go as high as 32. I've had people as high as 32. A significant minority do better at 24, but most are going to top out at around 16. That's the major effect that you're going to get is at 16 milligrams. And generally, if they're not going to be responding to 16 or 24 milligrams, that's the time to look at A, are they absorbing it properly? And B, should we consider moving them on to something like methadone? Next. This is really cool and really pretty and almost kind of useless from my perspective. But we're looking at the receptor, and you can see on the left there, there's mu1, mu2, kappa1, kappa2, kappa3, and delta. Those are the types of opiate receptors we have in our body, and they represent various locations on that fat old molecule which sits on either side of a cell membrane. And to some degree, mu receptors are more associated with certain types of effect: euphoria, sedation, prolactin release, peripheral analgesia, and supraspinal analgesia. And that's kind of why we're focusing in on mu receptor blockers or mu receptor things that have mu receptor activity because of the euphoria effect, the reinforcing effect of this stuff. Whereas with our delta receptors, way at the bottom there, you do get analgesia and some modulation of a mu receptor functioning. The kappa 1s, which do cause a certain amount of pain relief, spinal analgesia, but they're also responsible for the sweating, the meiosis, to a certain degree, the bradycardia and the pruritus. That's why when we give this to rats, they may get some pain relief from it, but they don't like to take it. You can't get rats to take kappa receptor agonists, no matter how much saccharin you give them. But they'll take mu receptor agonists like nobody's business. So number of different types of opioid receptors. We tend to focus in on essentially the mu1 and the mu2s. Next. Three things to think about when we look at opiate receptors. There's whether it's a full agonist, a partial agonist, an antagonist, and down below there, what they're really looking at is activity zone. In short, how much stimulation does that particular drug give the receptor? That's what they're talking about when they say activity zone. Underneath that is the affinity zone, and that is how avidly, with how much gust and zest does that drug bind to the receptor. And when we look at this, you begin to see this is why we get different effects of the drug. So heroin is a full agonist. So you'll notice there's a lot more of that thing sticking up into the activity zone, and there's a certain amount for the affinity zone. So it binds to the receptors quite easily, but it has a lot more activity to it. It stimulates that mu receptor, and that's what gives it its analgesic effect. It's also what gives it its euphoric effect, and why we like it. Buprenorphine, on the other hand, is a partial agonist. So you'll notice that there's actually more of it hanging below the surface than above. And if you were to take a straight edge, you would find that there's slightly more affinity for buprenorphine than for heroin. So buprenorphine binds to the receptors more avidly, more vividly. It will actually knock heroin off the receptor to get to it. But you'll notice what's sitting up there above the top in the activity zone, a whole lot less. This is why when somebody is using opiates and you give them buprenorphine and they're not in moderate withdrawal already, and you give them a good-sized dose, you can send them into withdrawal, because that buprenorphine is going to knock the heroin or other opiate off the receptor, but then it's only going to stimulate it at significantly less percent than the full agonist would. So you want to wait until they've got enough free receptors that when you give them the buprenorphine, it will cling to those receptors, stimulate them to a certain degree, not nearly as much as the heroin does, but begins to give them some relief from withdrawal symptoms. Now let's take a look at naloxone. Now, naloxone is the intravenous version of naltrexone. It's an antagonist, so there shouldn't be anything sticking up there in terms of the activity zone, and you see it's not. It doesn't stimulate the mu receptor worth a damn. However, it binds with that receptor very avidly. Again, take out your straight edge, and you'll find that it binds more avidly than heroin or buprenorphine. This is why when somebody's has overdose, we want to give them the naloxone, because it will push all the other opiates off the receptor, binds to them, and then prevent the opiates from binding to other receptors. It basically muscles in and takes over and shuts the whole system down. So one of the important points here is that how avidly the drug binds to the receptor is very important when we're looking at MAT and using different medications. How likely is that drug to push the other opiates off the receptor is going to tell you a lot about how it's going to affect the individual when you get them started on the medications. Next. Some good comparisons there about what our dose ranges are in the various and sundry medications and what conversion factors you use to kind of compare and contrast. There's, in my opinion, there's actually a whole lot better charts out there that give you comparisons, a whole lot easier, quicker to look at. It's just I didn't get a chance to, I couldn't find them. I know they're there, I've seen them before, but I haven't found them and be able to put them in this format. But there are conversion rates for all of these things. Take-home message on all of this is fentanyl is exceedingly powerful. It also has very high affinity rates and is one of the few drugs that will push buprenorphine, and for that matter, with enough of it, naloxone off the receptor. Next. So a busy slide that doesn't really tell you much, except that's what the stuff looks like if you've never seen it. The orange versus the white. There's still a lot of people.
Just different tablets.
Different tablets. And so it's when we switched from brand name to a generic, I think a while back, the VA did. There was a lot of argument about what was more effective, the orange or the white. And I think, quite honestly, it's highly variable. Some people absorb one better than the other. The glove there shows the old style injectables. Those were the rods that you could put in somebody, and it would slowly leach out of the rods. Yeah, those are.
I've never seen that.
Never seen those?
No.
But there on the right, you can see they come in all kinds, shapes, sizes. The tab or the strips, in some folks are better tolerated, they're absorbed better. But for some folk, they do have more problems with oral ulcers or oral sores using the tabs, using the strips rather than the tabs. Tabs you can kind of move around. The strips are going to stay in one place. If you do get oral sores and you have the opportunity, there have been reports that there's improvement with oral sores if you switch manufacturers of your strips. Some voodoo in one strip versus another. Next. If you guys got any questions, yell them out now.
Yep. Unmute yourself or write it through that chat box, please.
They say not to cut the strips too, but
Everybody does.
Everybody does.
Yeah.
And the manufacturer labeling lets you not divide or cut, but it's so commonplace.
So yeah, you're not supposed to, but it's actually fairly common practice, especially if you're trying to taper somebody off using strips.
Dr. Boo, go ahead.
Well, just to kind of ask, but maybe clarify that. So with the receptor affinity issues, it's going to be concentration dependent or dose dependent. Like buprenorphine will protect people from the effects of opioids up to a certain point, but at higher doses, it won't. Correct? And
well, actually, no, it'll protect them from the point of view of once I have all of my receptors covered, unless I give you something that's got a higher affinity for that receptor, it's not going to knock it off. But if I am having withdrawal symptoms because I've been using, say, 180 milligrams of oxycodone a day, and I try to use, and I've got a high tolerance, if I try to use my buprenorphine to cover those withdrawal symptoms. I may not be able to stimulate those new receptors enough, even if I cover all of them. I may not be able to stimulate them enough to be able to get the same type of stimulation that I was getting with my high doses of oxycodone. So they may still continue to have significant withdrawal symptoms, even though you're giving them very high doses of buprenorphine. So, I mean, they're there, but they're just not stimulating the receptors enough. Does that make sense? Do you see the difference? Or am I still too obtuse?
Am I muted?
Go ahead, we can hear you.
Okay. So like with the question of overdose, whatever, if somebody relapses and they're on buprenorphine, you're saying that as long as perhaps it's not fentanyl, which has a greater receptor affinity, that if they use some large dose of other opioids, they'll be protected from overdose. I thought they could exceed. Yeah.
Well, I can't say that they're going to be completely protected, but those opiate, the buprenorphine is going to cover them and make it less likely that they're going to have an overdose.
Okay, but they probably could take enough to have a problem. Yeah.
True, and they will try.
Yeah.
But I would say that unless we're talking about completely uninitiated opiate users, your average opiate user is going to be safer, taking something on top of his buprenorphine than taking something on top of his heroin, or his hydrocodone or his codeine. So the safety of buprenorphine is relative. For those people who are well experienced, it's a fairly safe drug. But let's have no doubts. If one of your kids gets a hold of it, they can kill themselves with this stuff because they have naive receptors and they're not used to being stimulated like that. So just like with methadone, you got to keep it out of the hands of the kids, and that's probably one of the biggest worries as we begin to use buprenorphine more widely. Is not addicts borrowing it and using it back and forth with each other, but family members, recreational users who really never experienced large doses of opiates getting a hold of it and dying that way, especially if they're combining it with alcohol, which most adolescents are doing.
Hi, can you guys hear me?
Yep, go ahead.
So sort of related, I just have a curious question. I have a patient who's on Suboxone who also uses a friend's methadone periodically and describes that doesn't get her high. She sort of describes it as a maintenance. I'm just wondering what those effects are in conjunction with her Suboxone. I don't totally understand how one trumps another, or
well, there's a lot of dynamics going on in there without really knowing how much of each they're using. It's difficult to say. Most of the, I've worked in the methadone programs as well, and there is no ceiling effect on that stuff. So yeah, you can get, quote, loaded, end quote, on methadone. And folks, in my experience when I've talked with them, folks who've been in methadone programs and also been in buprenorphine programs will often say that the buprenorphine doesn't give them that warm opiated haze that the methadone and other opiates can. This individual may be covering with methadone when they're out of buprenorphine. They may not have every receptor covered with buprenorphine depending upon their dose. They may not need it, but an added dose of methadone may give them some effect, but not a full agonist, get euphoric, get loaded effect. So as long as they're doing it intermittently, I think they're probably safe. Where you can get into trouble is when they start taking higher and higher and higher doses of methadone, somehow hoping that it's going to they're going to get loaded. That you might get into trouble. However, the half-life of buprenorphine is so long that it's kind of less likely that they're going to overdose on their methadone. If they do, it's going to be a day or so after they stop that little episode, when the methadone, which is very long-acting, is still in their system, and the buprenorphine, especially if they've stopped it, is beginning to leave their system. Then you've got more methadone effects on their receptors, which is a full agonist. Then you do buprenorphine effects on the receptors, which is a partial agonist. Now that makes sense in my head. I don't know if it did coming out of my mouth. The other thing I always got to throw out here is, I think some of the time there's also a strong placebo effect with all of this stuff. I had a patient who would inject his own blood because he knew we were checking his urine, and he would get a rush just from the process of drawing his blood, putting it into a syringe, putting on a ligature, and injecting his own blood back into him. So there is a type of placebo effect. There is an effect on the central nervous system through this force of habit. And so you can see people doing it just to try to recapture that the first time effect when they first use drugs. And sometimes they do get, some effect from that. It's not the physiology of their blood or anything. It's how they activate their central nervous system in old habitual ways and get a response from just doing that. By the way, how much methadone were they, or how much Suboxone were they on, and how much methadone were they using?
I think it was a 24-a-day TID dosing of 8/2, and then methadone shows up probably every other week, and she describes that it's just kind of intermittently, like she didn't have a Suboxone pill around. Methadone, I think, was her drug of choice of abuse prior to her Suboxone.
So I'd suggest it's the last one, because if you're using 24 milligrams a day, you've probably pretty well saturated all of your receptors. And so whatever effect she's getting has more to do with the behavioral process rather than the physiology of new receptor drugs.
That makes sense. Thank you.
Great. Thanks for the questions, everyone. I think we'll keep moving with the slides, but yeah, feel free to continue chiming in.
So with buprenorphine, you've got to do an induction. When you do the induction, how long you wait is before you start them on the buprenorphine is based on the half-life of the prior opiate that they were using and the time of last use. What you're essentially shooting for is a moderate withdrawal. It's a lot easier to get somebody on buprenorphine if they're using short-acting opiates like heroin. This is my opinion. Than it is if they're using really long-acting opiates where you've got to wait a long period of time. Most of the folks who've got opiate dependence, they can tell you exactly how long it is between their dosing schedules. And sometimes they can't wait 24 or 36 hours for these very long half-life medications. And so they don't show up for an induction. You just really can't get them in to start the whole process. Whereas with somebody who's got a short-acting opiate like heroin with a half-life maybe 4 to 6 hours, you can do that in a day. And there are some strategies, they're not considered good housekeeping seal of approval, but there are some dosing strategies that you can use that actually allow these folks to take the medication every 2 hours, or 2 to 3 hours, over a 24-hour period of time and induce themselves that way. You can only do that for short-acting opiates. Now, after you give them the drug, you've got them in your office. They're on moderate. They got moderate CAL scores. You give them a 4 milligram test dose. How long do we expect to see until they got some effect? 20 to 40 minutes. We usually wait 30. After about 30 minutes, they should be feeling something from that particular drug dose. And it's going to last anywhere from 24 to 42 hours, depending upon the individual and the state of their liver. Adverse effects can be cardiovascular, respiratory depression, pre-existing hepatic impairment, and abuse potential. Buprenorphine supposedly can interfere with other drugs. I think we'll get into that in a little bit. So if folks have got hepatic impairment, that's when you have to start looking at what other medications are they on when you're going to start their buprenorphine. I have not seen it worsen anybody's liver enzymes or liver function, synthetic properties, that type of thing. But there have been reports. After an hour on the medication, if they are still having withdrawal symptoms, you can give them another 4 milligrams for a total of 8 milligrams a day. And you can go up from there. So the next day, they can take between 8 and 12. The day after that, usually around 12. And that's where you want to at least wait for a couple of days. Because this is a long half-life medication, it's going to take you at least 5 days at any one particular dose to come to a steady state. So you need to tell your patients, yeah, you're going to continue to have some symptoms, but if you continue taking the same dose, you're going to get better and better and better each day. So every day in every way, we're getting better and better for at least 5 days at any one particular dose. Basically, if they're doing well on the dose, they can operate machinery and drive without significant impairment. Again, you better wait at least till they're at steady state before you take a look at them and decide, we've got them on the right amount, or sometimes you may decide we've got them on too much. Remember, if they're relatively uninitiated and they've been telling you that they're taking massive amounts of opiates and they really haven't, then you can get an intoxicating effect from buprenorphine, if given at a high enough dose. Next slide. Here we go. Buprenorphine is a cytochrome P450-3A4 inducer, or it's metabolized that way. So inducers like phenobarbital, which is used for seizures, it's still used for seizures. And I have seen some people, it's also used for migraines. You'll find it in some migraine compounds. Some people do try to recreate with it, but it's a lousy high. It is a sedative like Xanax. If they're on phenobarbital or rifampin, which is used to treat tuberculosis, dose increase may be required because the metabolization of those medications in the liver will increase the metabolization of buprenorphine and you'll chew it up quicker. Those that inhibit that particular enzyme, like ketoconazole or clarithromycin, and HIV protease inhibitors, a dose reduction may be required. So some of our patients, especially those with HIV and tuberculosis, and it turns up higher in our population than it does the general population, they may need dose adjustments depending upon what it's doing to their liver. We can use it in pregnancy. Risk of congenital abnormalities essentially is negligible and not demonstrated in rats and rabbits and hasn't been reported in humans. So it's now, buprenorphine is the drug and drug combination, frankly, of choice for those with, for women who are pregnant and opiate dependent. Next one. Naltrexone. Next. There we go. Pretty slides. Once again, kind of showing you the mu, sigma, kappa, and delta, or not sigma, but delta receptors. The important thing to remember is that the opiates are overstimulating the dopamine reward system, and while our endogenous, our naturally produced opiates, which include the beta endorphins, enkephalins, and dynorphins, they do stimulate the dopamine reward system, but not to the same degree, nor as frequently, nor as consistently as the opiates do. That dopamine stimulation that happens with opiates, it's the same mechanism that stimulates dopamine when we drink alcohol. So we can use this opiate receptor blocker to not only block the effects of opiates and the rewarding effects of opiates, but also to block the positive effects of alcohol and to decrease cravings over any particular period of time. I think it's, although this is a good slide to kind of point out to folks that yes, you do need counseling if you have a substance use disorder. I can go blocking regions in your limbic area and reward system, but those can easily be overridden by our thinking processes, and so ongoing counseling is really important to keep you from relapsing back to drug use. So these type of blockers can only do so much, and they can only help. They're a minor to moderate tool in the treatment of substance use disorders. They're not the end-all be-all. Next slide. Now, when we give naltrexone, we're specifically talking about the injectable form right here. So if I were to give you an injection of naltrexone, it's still going to take a good 2 to 3 days for the full onset of that opiate receptor blockade. It's got to leach out of that muscle tissue, and that's going to take a little bit of time, but it will last for about 28 days. Naltrexone is one of those medications where, just like in the example that was given earlier, people may try to override the effects. I know I've taken naltrexone, but man, I really got to, I'm not feeling good. I need to change the way I feel, and so I take some opiate, and it doesn't work. So I take more opiate, and it still doesn't work. And I keep increasing my dose with the idea that maybe I can overcome the naltrexone. I may not be able to overcome the naltrexone's effect on the mu receptor. But remember, some of the opiates we take also have kappa and delta effects as well. And so at higher and higher and higher doses of the opiates, I may get more and more and more of a kappa effect. And when you look at that slide, that busy slide we showed you earlier, you'll notice that kappa receptors are important in cardiovascular effects of opiates. And so, yeah, I may not ever get high, but I might kill myself through cardiovascular collapse, respiratory blockade. So depending upon what I'm trying to get loaded on, even though I've got my mu receptors blocked, that other opioid may be hitting other opiate receptors in the body and can cause me to overdose. Likewise, because I've blocked all my mu receptors, these suckers are going to become exquisitely sensitive, probably more so, we think, than in their native state before you started using opiates. And so when the naltrexone wears off, you can't just go back to what you were using before. You can't even go back to what you were using initially. You may have to go back to starting with very low doses of the drug and titrate upward to find your new euphoric effect. And it's because you've made those receptors overly sensitive, you are probably at a higher risk of overdose. Adverse effects, you can get nausea, headache. Those are the two I see the most. You can get agitation. You can get fatigue. They feel tired. And that's probably a kind of a more post-acute withdrawal prolonged effect. Because people coming off opiates will go through a period of time where they feel very fatigued. Decreased appetite. Now, we say it's contraindicated in acute hepatitis or liver failure or opiate use in the last 7 to 14 days. Hopefully, everybody can see why it's contraindicated if you haven't used opiate in the last, if you used opiates in the last 7 to 14 days, because you're likely to have a very nasty withdrawal effect. But the acute hepatitis and liver failure has to do with the fact that naltrexone can cause acute hepatitis, can worsen liver enzyme, increase liver enzymes when you first get started on it. The information from the manufacturer, if you want to believe them, and I don't, it says that the acute hepatitis effects are actually quite minimal. I haven't had any yet, but it has been reported. The one thing I do want to point out, however, is although naltrexone may affect your liver, the liver does not affect naltrexone. So the reason that it's contraindicated is it might make your liver enzymes worse. But if you have a bad liver or have chronic hepatitis, that's not a contraindication to using naltrexone. You don't even have to have a dose adjustment because naltrexone, instead of being oxidized, which is what the liver does, it is glucuronidized. And that happens in a bunch of other places in the body, not just the liver. So you can give standard doses of naltrexone to somebody who's got a bad liver and not have to worry about, do you have to adjust your naltrexone? You may have to worry about, if I start him on the naltrexone, am I possibly going to take this liver that's a little bit ticky to begin with and kind of push it over the edge? That would be your only real worry in those situations. You also have to worry about whether or not there are components in the medium that you're given the naltrexone in that somebody might be allergic to. The first time I used naltrexone in a shot form, the guy had been on it orally for months. We gave him the shot and he had a massive anaphylactic reaction. It wasn't the naltrexone, it was the agent that we're using to push the naltrexone into his system. Now, how about efficacy? In terms of naltrexone versus buprenorphine, they are the same. In terms of whether people remain in treatment and whether they complete treatment, most of your information shows naltrexone and buprenorphine have got the same if your outcomes are not using drugs and staying in the program. There's an advantage to naltrexone, however, and that is that they're already substance-free. They're already opiate-free when you're giving them the naltrexone. The problem with the buprenorphine is that when you go to taper it, let's say 6 months, 9 months, 12 months from now, you are going to destabilize them. They are going to be more irritable, more restless, more discontented. They're going to have affective instability. They're coming off another opiate. Granted, it's in a more controlled fashion, and you hope with your therapies, they now have better coping skills, their life's in a better position, they've got something to look forward to and to live for, and they've had some life skills and practice how to deal with negative emotional states without reverting to drugs, but you can better expect that they're going to have a certain amount of emotional problems as you do a long, slow taper off at the end of all this. Whereas with naltrexone, they're generally not even feeling it once you stop the injections.
Yeah, so you just discussed it a little bit. Any other benefits to naltrexone over Suboxone, since it seems like patients would feel a little bit better on Suboxone?
Well, I used to like to say naltrexone is a great medication that nobody wants to use. Patients don't really want to take it. And I think some of that is just it's scary. Okay, we're going to take something I know that I use, that's my friend, and instead of using its cousin, buprenorphine, I'm going to look at you dating its ugly stepsister or stepbrother. I mean, it is the antithesis of what I'm used to. And so there is, I think, some not inherent barriers, but some attitudinal barriers on patients' parts to using naltrexone. One of the best ways to overcome that barriers is to introduce the individual into the criminal justice system, okay? Who, because of their own sets of values, dubious that they might be, are very much opposed to using any type of opiates and will promote the use of naltrexone. And for those in the criminal justice system who've gotten started on naltrexone, not only do they like it, but they do very well. So if I've got somebody coming into me and I've got a chance between using naltrexone and buprenorphine, and they're going into the criminal justice system, naltrexone's got in my experience, at least around here, a much better chance of keeping them out of jail than putting them on buprenorphine and then having them go through the criminal justice system. Judges tend to look more favorably if they're on naltrexone than they are buprenorphine, at least around here. Your mileage may vary depending upon where area of the country you're in.
Thanks for the question, Emily. Any other questions out there right now?
We're doing star 6.
Go ahead.
Okay, now
Yeah, hi, Tom Boo. So,
I have a question.
The problem that was described with getting people off of long-acting opioids on a buprenorphine, isn't that the biggest barrier to using naltrexone outside the criminal justice system, that people just don't make it through withdrawal? I mean, 25% of people in this studies never started. Yeah.
I'm not sure I understand the question.
Okay. Well, for buprenorphine, you want to start people when they're in withdrawal, but with naltrexone, they have to be completely through withdrawal and abstinent for a while, and a lot of people don't make it. Isn't that the biggest practical barrier? Yeah.
Well, again, it depends upon your setting. I'm part of an inpatient psychiatric setup, so I can hospitalize these guys if I want to over a period of time and very tightly control their medications. And so I can use lots of different medications that you wouldn't try at home for withdrawal, and I can get a lot higher than 25% through a withdrawal phase. But if you're doing this for the masses on an outpatient basis, yeah, that is a problem. What I find is that people who come to me saying that they want a non-opiate based treatment approach, but they want some help medication-wise, I'm going to give them a try on naltrexone. If they fail naltrexone, I can always go back to buprenorphine. But if they come in saying they want buprenorphine, it's a much tougher sell to get them to try naltrexone. Those who are going to do best on naltrexone are most likely those who can go through opiate withdrawal relatively easily. Sometimes that's dependent upon how much opiates they're using. Sometimes it's not. You'll occasionally run into a person who can take large amounts of opiates, and when they quit, they don't have withdrawals. It's the damnedest thing. I cannot explain it in any way, shape, form, or another except to say I've seen it. And I believe how much they were using. but you're right, Tom. The major thing is that they're not going to want to try it because they're not going to try to get through the withdrawal phase.
Just a quick follow-up question. If somebody wants, if we're interested in transitioning someone from buprenorphine to naltrexone, how long do you reckon they'd have to be off the buprenorphine before you could start the naltrexone?
I like a month myself, but I think you can go a couple of weeks. Is what's reported is a couple of weeks. Get them if at 5 half-lives, you're talking a week. 2 weeks, well, that's two half-lives. It should be out of their system. The reason I like to wait a little bit longer is because if they're going to have some withdrawal symptoms, and you're going to have withdrawal symptoms, I want them to attribute that to coming off the opiate rather than starting on the naltrexone.
Thank you very much. I got to bail, but it's been a very helpful session. Thanks very much, guys.
Great. Thanks so much.
Tom, thanks.
Good to have you. Northern Inyo, did you have a question?
I have a question about using Vivitrol to help people get off of alcohol. How long do they need to be sober? We have a pharmacist who insists on 36 hours, and that's a hard window to meet.
Yeah. For me, I don't care. To be honest with you, there is absolutely no evidence that suggests it's any more or less effective when it's initiated while you're drinking as opposed to while you're not drinking. If there's any issue, it's going to be, once again, with the liver. And I don't think 36 hours is really going to tell you a whole lot.
I appreciate that. Thank you.
In fact, if you really want to get down to it, there is a protocol out of Sweden which only gives Revia, oral naltrexone, on the days that you go out drinking, so that you actually take it before you drink. And they've shown decreased number of drinking episodes and decreased amount of drinking if you start taking the drug right before you start drinking. So there doesn't appear to be any medical or metabolic reason for your 36 hours.
I wonder why they gave that 36-hour number. Why did they give that 36-hour number?
Okay.
Okay.
Thank you so much for the answers. I appreciate it.
Okay. Mary has a question about patient education materials for the medications, specifically for patients with low literacy levels. Does anybody know anything?
I mean, you can go to the pharmacy and they give you pretty patient-friendly, I guess. I mean, in kind of as lay terms as they can give. They can give you a pamphlet on that.
And Mary, I'll look around and see if I can find some other things for you as well. And it looks like Annie just shared a link as well. So, all right, I think we've just got a little bit left here, and then we'll wrap up for the day.
Is there anything left?
Oh, that's
well, that was
there.
it.
Okay, good timing. All right, thanks so much, everyone. So we'll be back a couple weeks, August 28th, talking about the principles of harm reduction. So hope to see you then. In the meantime, please keep thinking of specific patients you want to discuss with us and any other questions you have. So see you in a couple weeks. Thanks, everyone.